Hello, my name is Richard Schell. I'm a pulmonary specialist here at Nationwide Children's Hospital caring for patients living with neuromuscular disease. I'm glad that you have chosen to watch this video and hope that you come away today with the information necessary to care for patients with Duchenne muscular dystrophy. Emergency care of these patients is as complex as this disease process itself. Making decisions can be very difficult at times. Dr. Gary Nortz has specialized in the care of these patients with complex medical needs, and we'll be discussing today the important aspects of caring for patients with Duchenne in emergency situations.
There are several common scenarios by which an adult with Duchenne may present for medical care in the acute setting. One would be dyspnea, palpitations, abdominal pain, back pain, or pain in a limb or swelling of a limb. We'll talk about some of the specifics of this. So, the first important thing to remember is that something may happen to a person with Duchenne just as it may happen to a person without Duchenne, although certain things are more common in patients with Duchenne muscular dystrophy. Each of these scenarios needs to be evaluated in the context of the expected complications of the disease or the treatment that they're on. I want to stress that it's really important to trust the patient and their caregivers when taking the history. They know the backstory. They know the treatments the patient has received. They know what their pain tolerance level is. And they know how much trouble they're having breathing, for instance, even if it's not immediately seen when you examine them. The differential for dyspnea in somebody with Duchenne, just like other people, can be broken down into problems with ventilation, oxygenation, or worsening cardiac function. In terms of ventilation, there may be a decrement in muscle strength during an acute illness, such as a viral illness, or any ventilatory support that they're already taking, such as BiPAP, may be malfunctioning or functioning poorly, and so that needs to be evaluated. In terms of oxygenation, there could be problems in the parenchyma, such as pneumonia, pleural disease, VQ mismatch, as you might see with a pulmonary embolus, anemia, or even an upper respiratory infection can cause trouble breathing and difficulties with both oxygenation and ventilation. Simple viral illnesses can be very serious in patients with already corrupted ventilatory status. We often may see worsening of cardiac function, either from worsening of the cardiomyopathy, fluid overload, arrhythmia, not taking their cardiac medications as prescribed, and there may also be a significant anxiety component, which can cause shortness of breath. In terms of evaluation, the history is extremely important, as is the exam. Patients may have impending respiratory failure even though they look fairly well. Unlike other patients who are entering the late stages of respiratory insufficiency, they have difficulty recruiting accessory muscles, and so you may not see retractions or abdominal breathing, whereas the only thing you may see is tachypnea. Also, the weakness of the facial muscles may belie how serious the illness is because they can't make as great expressions with their face as you might expect. The imaging in laboratory is pretty standard for evaluating of dyspnea, such as a chest x-ray, a blood gas, and so on. The treatment really depends on the cause. I really want to stress that you should not use oxygen empirically. Patients with Duchenne should be assumed to have hypoventilation and thus rely on a hypoxic respiratory drive, much as patients with COPD do. And so to put oxygen on them without recognizing the degree of ventilatory dysfunction can impair their respirations further. Patients who are experienced users of BiPAP can often just put their BiPAP on, often at increased settings, and this may help them get over periods of dyspnea. If a patient with Duchenne should require intubation, certain things are important to remember. First of all, the depolarizing muscle relaxants such as succinylcholine should not be used due to the risk of rhabdomyolysis and hyperkalemia. Inhalational agents may be associated with malignant hyperthermia. And so it's generally recommended, if intubation is necessary, to use agents such as propofol, etomidate, vecuronium, or cisatracurium. It would be wise to prepare for a difficult intubation and to make sure there are experienced personnel available when intubation is planned, particularly if it's planned urgently. The airway itself may be smaller than you're used to for adults of the same age, and the opening of the jaw may be limited by contracture, and so it may be difficult to adequately visualize the vocal cords. Sometimes fiber optics would be necessary. In terms of dyspnea treatment, opioids in low doses and carefully monitored can be used safely. Mucus clearance is of paramount importance, and in terms of moving the mucus from either an upper respiratory infection or pneumonia, may be even more important than the antibiotics for getting somebody through a respiratory illness. For those patients who require intubation but are experienced BiPAP users, BiPAP can be used as a bridge to extubation, as they are already used to using this technology. In terms of heart failure, you have to have a high degree of suspicion for this because the history may be kind of vague and nonspecific. The patients may complain of fatigue, weight loss, or vomiting, and not really dyspnea, but that may happen as well. The exam can be quite difficult, and so it's important to try to get a weight, but that can often be difficult to do even in a patient in a wheelchair. EKG and rhythm monitoring is important. Labs such as a B natriuretic peptide can be helpful in sorting out whether a person's in heart failure or not, and imaging with echo would generally be preferred in the acute setting, even though cardiac MRIs are often used chronically to monitor the heart function of these patients. The treatment is fairly standard, as with other causes of heart failure. Diuresis is used to reduce preload. Afterload can be reduced with ACE inhibitors, nitrates, or other vasodilators, and if there's dysrhythmia, that should be treated as well. Often these patients, in conjunction with a cardiologist, might receive resynchronization therapy, left ventricular assist device, or even transplant. For adults with Duchenne who present with abdominal pain, there can be a myriad of causes, both serious causes and not so serious causes. Common things that we might see would be reflux, gastritis, or peptic ulcer disease, constipation, but also surgical diseases such as ileus or volvulus, kidney stones, and heart failure can also present as abdominal pain. The workup and treatment for this, again, depends on the cause and is fairly standard. Many of the adults with Duchenne complain of back pain. One reason might be kidney stones. Another could be a compression fracture of the vertebrae, which is often seen even without the use of steroid treatments, but much more so for men that use steroids. Discomfort just from the way they're seated in their chair can often be the cause of this discomfort. The standard treatments for these apply as well. Should a person with Duchenne come in with a swollen or painful leg, it's important to think about fracture, as this is more common in any patient that does not use, that is not ambulatory, but also in those patients with high-dose steroids. Blood clots are possibly more common in patients with Duchenne and Becker muscular dystrophy. The workup for these, again, would be X-ray, Doppler ultrasound, and anticoagulation should be very important for somebody found with a DVT, but also for anybody who's had a fracture. Thank you.